Thank you.
Good afternoon, everyone. We are going to discuss principles of chronic pain management this afternoon. So what we want to do is to help us understand what chronic pain is, how to classify, how to assess chronic pain, and basically what options are there to manage patients who present with chronic pain. Pain has been defined as an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage or described in terms of such damage. That is the definition by the International Association for the Study of Pain. Now, pain is a very subjective experience, and even if you get patients who have a similar pathology, they do not experience pain in the same way or will not describe it in the same way. So we have many factors that influence how we experience or how we describe our pain. For example, our age, culture, our previous experience of pain, even our experience with the healthcare systems will really affect or influence how a patient will describe their pain for you, or even how they will seek help when they have pain. So pain is classified in 3 ways. Simply, we can classify it by the mechanism. The mechanism means the underlying pathology, the way what is causing the pain. Then we can look at the duration. The duration is acute or chronic pain, and then the etiology is the cause of pain. So we can say this is pain due to cancer, pain due to trauma, pain due to a procedure. So acute pain is defined as pain that lasts to the healing time, and healing time is thought to be at least 1 month. So traditionally, chronic pain is defined as pain that lasts beyond the normal healing time. So for patients without cancer, that is non-malignant pain, 3 months is given as the cutoff time. For research purposes, chronic pain is considered to be pain that has lasted for at least 6 months. Then now there's the question of patients who have a condition that is likely to recur. They might be presenting with pain, for example, trigeminal neuralgia. The pain gets relieved and then again it recurs. So is recurrent pain to be considered as part of chronic pain, or it's a different pain syndrome? For now, we don't have that answer yet. Chronic pain is just defined based on the timing, how long the pain has lasted or how long the pathology has lasted. Then again, there's the issue of prognosis. There are patients whose conditions are incurable, or they are likely to have pain. We can predict that they're likely to have pain for a long time. So that should also be a way for us to look at which patients are likely to present with chronic pain. How can we prevent this pain and how can we manage it? For example, patients with cancer, when they have metastasis, it is very likely that that patient is going to have pain in future, even if they do not have pain now. So we should be able to be aware of what kind of pain we expect the patient to have, what kind of care we want to give them, and what kind of follow-up we want to give them. So pain, of course, is poorly understood, it's poorly studied. And the first problem with pain management is that it is poorly identified. And most of the time, patients presenting with pain are dismissed, especially the ones with chronic pain. Patient will present and say they're in pain, but the healthcare provider will dismiss and say this patient does not look like they're in pain. Or because the patient has been living with their pain, they're sort of used to having the pain. So it is not considered a big deal. Chronic pain is thought to affect 20% of the world population, and the prevalence is anywhere from 7 to 55%, depending on which condition we are talking about. Lower back pain, for example, is very common in the society, and when you sit in an A&E department, many patients will present with headaches or lower back pains. So this chronic pain affects productivity of individuals, and of course that will affect the economy and the development of the society at large, because if we have people taking a lot of sick offs because of having pain, then in the end, we all become affected. Now we'll look specifically at how to classify chronic pain. The first classification, we can look at how the pain is impacting the patient. So chronic pain can be any kind of chronic pain. So that would be any pain that has persisted beyond 3 to 6 months, or any pain that recurs. That is any chronic pain. Significant chronic pain is thought to be chronic pain that makes the patient visit the hospital frequently and is on medication a lot of times. That is pain medication. Then severe chronic pain is thought to cause disability. So this is a patient who has pain, but on top of the pain, the patient has some disability. They're not, either they're bedridden, they're not able to use their limbs, or they're not able to function because of having pain. The other way to classify is by the mechanism of the pain, where we have nociceptive, neuropathic, and mixed pain. So nociceptive pain is pain that originates from muscles, skeleton, skin, connective tissue, and organs. Then neuropathic pain is pain that originates from nerve damage or problems in the nervous system. And mixed pain it has both a nociceptive and neuropathic component. So mixed pain, it means that a patient has manifestations of pain that tell us this pain could be coming from nerves as well as from muscles or from bones or joints. So mixed pain is actually more common than just purely nociceptive or neuropathic pain. Then when we come to nociceptive pain, we can further subdivide it into somatic and visceral pain. Somatic pain will be from the joints and muscles, and visceral pain will be from the hollow organs. So patients describe pain depending on the affected tissues. So for neuropathic pain, for example, patients give us words like the pain is burning in nature. They'll tell you it feels like a fire, or it feels like pins and pricks, stabbing, electric shock kind of feeling. And for nociceptive pain, they'll mostly describe it as a dull ache, stiffness, tenderness. They'll describe it as this constant, persistent pain. Now, neuropathic pain is usually very hard to manage because of the kind of mechanism of how patients get pain, or the kind of problems that will result in neuropathic pain. So we end up using a combination of analgesics for that, but we'll come to that at a later slide. So examples of chronic pain disorders, we'll start with the list on the right, that is nociceptive pain. So we might have patients presenting with low back pain, arthritis of different kinds, chronic inflammatory problems, postoperative pain, sickle cell, sports injuries. That is nociceptive pain. Neuropathic pain can come due to neuropathies, and the neuropathies could be because of diabetes, HIV, or treatment associated, like in cancer patients. Diseases like herpes lead to post-herpetic neuralgia. We have trigeminal neuralgia, post-stroke pain, spinal cord injury, and neuropathic lower back pain. Then mixed pain, we have migraines, chronic headaches, fibromyalgia, complex pain syndromes, multiple sclerosis, lower back pain, myofascial pain syndrome, and skeletal muscle pain. Now, this table is just for us to have an idea of how diverse chronic pain is, that we can have very many conditions. And even this one patient who has rheumatoid arthritis or osteoarthritis, for example, might also be having diabetes. They might come with the pain due to arthritis and still have pain due to a peripheral neuropathy due to the diabetes. So chronic pain is not a straightforward topic. It's actually complicated because the way these diagnoses are varied is the same way the patients present in a varied manner, and also with a lot of other things that we have to consider. So when we are assessing pain, or when a patient presents with pain, we need to remember that pain is multifactorial. We cannot blame the pain on one thing. Sometimes it's even hard to isolate the cause of the patient's pain, but we still have to manage it. So pain, of course, it's the physical pain that brings the patient to hospital, but we have to look at other factors that influence this pain. For example, the behavior of the patient. Psychologically, how are they affected by having pain? And sometimes we've had patients who come to the clinic several times. They do not have a diagnosis. We are not able to isolate the cause of their pain. They are on painkillers and they don't know how long these painkillers are going to go on for. So of course, the patient will have some concerns. They might have some anxiety. Then there's the socio-economic impact of having pain. Analgesics are not cheap. If someone has to take pain medication every single day, there's the issue of the cost. Some of the investigations we need to do to arrive at a diagnosis or even treatment for an underlying problem, they come with a lot of socioeconomic stresses to the patient. And of course, there's spiritual and existential issues that come about with patients being sick or having chronic illnesses. So when we are assessing pain, first we need to define what our goals are. So the first thing is to try and determine the etiology or the underlying cause of the pain and to determine if the cause is treatable. Before we resign to just managing pain, we need to have established either a diagnosis, we have a working diagnosis, or at least we have an explanation of what is causing the patient's pain and what we are expecting. Then we need to determine the impact on the patient's life. That is, how is the pain affecting their quality of life? How is somebody having chronic pain affecting their productivity at work, their relationships at home, even their ability to even come to hospital or to follow up with the clinics that we're giving them? Then we determine the best measures to control the pain. Now, these measures, put it here as the best measures, not the best analgesic, but the best measures. Because pain will not be controlled only by analgesics. We have to look at the whole picture. You have to look at the patient in totality. What other factors are there that need to be considered or need to be controlled in order for the patient to be comfortable? So pain assessment starts with history. Even for chronic pain, the normal history that we take for a patient presenting with pain. We want to know, when did the pain start? Where is the pain? What is the characteristic of the pain? The patient will describe it in the words that we've said. Is it a dull pain? Is it a shooting pain? Is it a burning pain? Then does it radiate anywhere? What interventions has the patient tried for that pain? So do they get any relief or aggravating factors? And when we take pain history, we also have to take history of medication. In Kenya, we know we have a challenge with over-the-counter medication, especially NSAIDs. Patients buy a lot of over-the-counter analgesics, so it's good to know whether the patient got a prescription, whether they've been self-medicating, and what is the frequency of the medication they are taking and any side effects. You'll find our prescriptions or our medication is dispensed written 1 times 3. So the patient takes a tablet at 8 in the morning, at midday, and at 4 p.m. and they tell you, I took 3 tablets in a day. So we need to find out what is the dosing of the medication like. Then what are the comorbidities? What other problems does the patient have? Are they diabetic, hypertensive? Do they have renal problems? Then the next thing is to examine the patient. Find out the area that the patient says has pain. Is it tender? Is there any swelling? Is there any obvious pathology that you can pick up on examination? Then send the patient for relevant investigations. Now, from this point of assessment, it is good to have a working diagnosis, and where possible, the patients should be referred early so that their interventions can be given early enough. For example, if you're taking a history and you see this patient is likely to be having some neuropathic pain and might benefit from interventions like nerve blockade, the patient should be referred early instead of putting them on analgesics for 6 months before now referring them to an anesthetist to see whether they can do invasive pain management. So the scales that we use within KNH is the numeric pain scale. So this is purely for the severity of pain. So a patient chooses for us on this scale between 0 and 10, a number that corresponds to their pain. So 0 is no pain, 1 to 3 is mild, 4 to 6 is moderate, 7 to 10 is severe. This scale is applicable to literate patients, and for children, we start using it at the age of 9 when they know how to count. For the ones who are illiterate or for children, we can use the Wong-Baker Faces scale. So this scale has faces that correspond to the degree of pain. So again, you explain to the patient that you want them to choose a face that corresponds to the pain when it's at the worst. Now, the essence for rating pain is so that we can manage it well. So after proper assessment, we then decide what is the best way to manage the pain. And after doing your assessment for physical pain, you have to look at the other problems, social, psychological, and spiritual problems that might be associated with the pain. Because sometimes we've said patients have psychological pain or psychological problems. Remember, those psychological problems or psychological pains need psychological interventions and not analgesics. So we need to identify and also link up the patient with the relevant support. The goal of managing pain is to cure the patient where possible. If you can establish a curable diagnosis, then the patient should be referred through the correct channels for us to try and achieve cure. Where cure is not possible, then we need to manage the pain. And to decrease the suffering of the patient, rehabilitate them, depending on what functions have been inhibited by having pain, and basically help your patient to cope with the problem that is causing them to have chronic pain. So these management goals, we set them. They have to be individualized. Patients, as we've said, are not the same. They come with unique problems, unique setups, unique social support. So we have to involve the patient in managing their pain, first by having a discussion with them and coming up with an action plan of how to manage their pain. This WHO 3-step ladder is what we use to manage patients with chronic pain. And after we've evaluated and rated their pain, we come to the ladder, which has 3 steps. So step 1 is a mild pain where we use NSAIDs and paracetamol. Step 2, we use moderate pain, we use weak opioids. And step 3 is severe pain, we use strong opioids. Now, remember, before you write a prescription, you have to look at the overall picture. How long is your patient going to be on analgesics and what is the long-term plan? That's why I'm emphasizing that it is good to have a multidisciplinary team manage the patient, or also have a referral channel, so that if a patient needs invasive pain management, it can be done early, because that is now where we go after this pain medication has not worked. So the approach for managing chronic pain, first of all, is for us to be flexible and individualize the treatment plan. Now, flexibility comes in terms of choice of analgesics. There are many factors that will influence how we choose medication for patients. First, of course, is the medical profile of the patient. What is the age of the patient? What problems do they have in terms of comorbidities? What is their baseline renal liver function? Then now let's look at other factors. In Kenyatta is a referral hospital. So we have patients from all over the country. Where does this patient come from? This medication I'm prescribing, is it available in Kwale as I'm referring the patient back there? What is the cost of the medication? How often does the patient need to come to the clinic? What other kind of investigations will the patient need in future, or what is the long-term plan? So that's what we mean by an individualized treatment plan. Then interventional pain management should be done from early stages when we've identified pain that is likely to recur or that is likely to not respond to normal analgesics. The patient is going to go home with 5 drugs, 6 drugs. can we consult the anesthesia team so that they can also help us to evaluate the patient and see if there are other permanent ways of sorting out their pain. Then there is the role for multimodal analgesia. That means that we can prescribe combination medications or more than one drug. I'll go back to this ladder. At every step, there's a plus or minus an adjuvant. Adjuvants are medications whose work is not to control pain, but they have a role in pain management, either by working on the pain pathways or by potentiating the action of analgesics. So the common adjuvants we've used, and we mostly use adjuvants for neuropathic pain, are anticonvulsants. We can also use steroids and antidepressants. So management for chronic pain, just as we said, it's complicated, it's complex. After prescribing your medication, look at other options. What other things can help the patient cope with their pain? Do they need physiotherapy? Do they need occupational therapy? Is there a role for a psychologist, that is psychotherapy? Do we need any interventional procedures? Does the patient need to modify their lifestyle, do more exercise or less exercise, modify their environment so that they have less pain? And then what are the non-pharmacological therapies that can help? Things as simple as just a patient listening to music, reading a book, drawing, gardening. Hobbies of the patient can actually help them to be distracted from the pain, and there are techniques that have been studied as non-pharmacological therapies for pain management. So now for drugs, this is the last slide now. We'll look at what kind of drugs are available for managing chronic pain. So I'll go through them briefly. So first we have the conventional analgesics, that is NSAIDs, and we have opioids. So NSAIDs and opioids, we will use the WHO ladder to decide which medication is appropriate for your patient, and we consider patient factors. Then we have topical agents sometimes can work, like topical anesthetics. We have adjuvants, the anticonvulsants and the antidepressants. Then we have non-pharmacologic therapies. This is what we're talking about: behavior, cognitive therapy, physiotherapy, counseling. Then we have regional nerve blocks, and we have a good team of pain management specialists in this country. Some can help us with the nerve blocks. Then other interventional techniques include peripheral neural stimulation, spinal cord stimulation. The anesthetic team will probably take us through this in future about invasive pain management techniques and the kind of patients that need that. So in conclusion, when we meet a patient with chronic pain, our primary role is first of all to properly assess the pain by taking a good history, understanding the factors about the patient, and looking at the pain in totality, not just the physical aspects of the pain, but all aspects surrounding that patient. Number two is to try and establish an underlying diagnosis, and where possible to try and refer the patient so that they can get cure. And our last role is actually to manage the pain. So as the patient goes through their treatment or investigations, please do not leave the patient in pain. Thank you.
Yeah, thank you so much, Dr. Nafula, for that very educative session. I know we don't have too much time because we have another session beginning in at 2:45. So we'll go to the questions which have been posted on, and I'll also invite our attendees. If you have any question, please use the Q&A to send your question. So just give me a minute. I get. Sorry. Yeah. So the first question is from Jebet Sirma, who is asking chronic pelvic pain after cesarean section. Under which category would you put that?
Now, Jabet, that is, of course, when we say chronic pain, we need to look at what is the duration after the C-section. And then you have to look at what might be causing the pain in that patient. Does the patient have other pelvic pathology that might be causing their pain? Or is it just purely because of the C-section? Were there any complications during the procedure? Because it is most likely to be a mixed pain. So that's a patient who needs proper evaluation, possibly an MRI, and assessment to see what the cause of their pain is and what would be the ultimate treatment.
Okay, we'll go to the second question. This one is from Evans Sumba. And the question is, what is the best way to manage pain in pregnancy without any risk? Is it advisable to use non-steroidal anti-inflammatory drugs?
Okay, now that's a tough question for me because I am not a gynecologist, so I am not very sure about safety profiles of analgesics. Maybe allow me to skip that one, unless there's a gynecologist in the audience who might be able to help us. Because I know it's a bit dependent on the gestation also.
Okay, so I think we'll skip that. We'll go
Yeah.
to the second question. What advice can you give to those patients who totally depend on maramoja? Whenever they use another pain reliever, it does not help. But when they use maramoja, they get well on daily basis. How can you advise on that?
Sorry, that question has made me laugh a bit. Now, a patient who's using maramoja all the time, first of all, that is a patient whom we need to establish whether they really have pain or they're using maramoja because it has caffeine. So that is, we need to really evaluate that patient's pain properly, because what is the cause of the underlying pain? Why are they taking maramoja every day? But my experience with patients and painkillers, patients sometimes tend to believe that this is the only medication that will work for me. And when you take a history, you find that the patient was probably in a lot of distress due to their headache or their pain, and that is the medication that was prescribed. So the patient forms a belief that this is the medication that can help. So remember, we said when we are managing pain, we have to discuss with the patient, we have to involve the patient. So when we are prescribing medication, also inform the patient, this is why I'm prescribing this medication, this is why it is good for you, and maramoja is not the only option that can manage your pain.
Okay, thank you for that. We have another one who is asking, where do you classify pain from adhesions, which came following cesarean section? And especially if it has been going on for some time, over 2 years, is there something that can be done? What would you recommend?
Yeah, now pain from adhesions is chronic pain, actually. It's usually a complication of abdominal surgeries. And it's pain that comes on and off. So most of the time, what we do is to try and just work with the patients, because these are patients, again, the only way to treat adhesions is to release them, and going to theater to release adhesions causes, again, more adhesions in future. So I think first is to try and see how much analgesic the patients needs and for how long. Because sometimes when we are able to manage the acute pain well, because they get episodes, the pain from adhesions is episodic. So they get episodes of acute pain, then sometimes it's just chronic persistent pain. If it is regional pain, again, we can advocate for having nerve blockade if it is very well defined in the region, so that the patient is not dependent on analgesics.
Okay, thank you for that. Another question. Yes. The next question is, can one combine Traumadoll and beta pain?
Okay, now that is combining opioids. Now, Traumadoll is a moderate, it's a weak opioid, sorry, not moderate. And the tablets come 50 milligrams, 100 milligrams. Then beta pain is a combination of paracetamol and codeine. So the answer for that would be no, because you have to choose which medication do you want and at what dose, because codeine and tramadol both fall in the category of weak opioids. So there is actually no role in giving both tramadol and betapine. You better optimize one analgesic. Or if you want, because the combination medicines have an advantage where when you have paracetamol and codeine, so you have a bit of paracetamol, a bit of codeine, you give your patient one tablet instead of giving them a prescription for codeine, a prescription for paracetamol. But now you have to look at the dosing of the combination.
Okay, thank you. There is quite a lot of appreciation for the very good presentation. Next question is, can you comment about depression and anxiety and how they may be affecting perception of this pain? If you have any comments or.
Okay, now depression and anxiety are a psychiatric diagnosis that actually have a criteria, but loosely looking at it is any patient who has a chronic illness is likely to have some degree of anxiety because they will be worried. There's concerns about the future, concerns about your illness, the treatment might not be working. So when patients have unresolved psychological problems, whether it is full-blown anxiety, depression that needs more than just psychotherapy, their pain tends to be higher, their pain perception. They'll tend to report more episodes of pain, and usually it's because of also the psychological issues going on. So there's a big role for us to counsel our patients, and counseling patients does not have to be a whole hour counseling. Even just educating the patient that this is your diagnosis, this is why you're having pain, explaining to them to understand why they're having pain, what the medication is going to do for them, how long it is likely to last. It relieves part of that anxiety.
Okay, thank you. Thank you. The next question is, what is the maximum dose of parental Traumadoll that should be given in a day, in 24 hours?
That is IV Traumadoll.
Yes.
Is it for an adult or a child?
I believe here they are referring to an adult.
Sorry, again, we would look at whether it is post-operative or why the patient is on IV Traumadoll, but it's about 400 milligrams in 24 hours.
Okay, thank you. Next question is ladder applicable to children?
The pain management ladder.
Yes.
Now, pain management in children, the ladder is applicable, but the ladder for children has been modified and for cancer pain. So I think we should probably in future organize a session for managing pain in children, because we have to look at whether it's acute or chronic pain. So this ladder that I have shown, let's use it for adults for now, because the children ladder has been modified because of many other issues with opioids, especially the weak opioids.
Okay, thank you. Next question is, if you are to give amitriptyline as an adjunct for chronic pain, what would be the recommended dose you would recommend?
The starting dose for amitriptyline is 25 milligrams per day in 24 hours. And remember, when you're giving amitriptyline, it's an antidepressant. So you have to warn the patient that you're not giving them because they're depressed. And then you have to look at the medication the patient is on so that there are no interactions with the amitriptyline. But the starting dose is 25.
Okay, thank you. We have a question from Gladwell Mudike, who is asking you to explain rationale why you would want to give different classes of analgesics together. For example, giving NSAIDs and opioids.
Okay. Now, the analgesics have different mechanisms of action. For example, NSAIDs work by blocking cyclooxygenase enzymes, so by inhibiting prostaglandin synthesis. When opioids work by binding on opioid receptors that are found in the central nervous system or in the central nervous system. So the reason for combining pain medication is usually so that you're able to address the different pathways of the pain. So when we were classifying pain, we said there was nociceptive, which was somatic and visceral, then there was neuropathic pain. So when you want to combine analgesics, you have to understand the pathogenesis of the pain. For example, NSAIDs will work where you are trying to inhibit prostaglandins, and opioids will work where you are trying to work on the central nervous system. So the rule of combining medication is to use medication that work on different pain pathways.
Okay, thank you, Daktari. And next question is from Norbert Peshu, who is asking about the side effects experience with the pain medicine for chronic pain management. What is your experience, and what can you advise based on what you've seen?
Okay, in my experience managing patients with pain, actually, I always aim to try and keep the patient on analgesics for as short a time as possible, unless, of course, they have, let's say, a cancer diagnosis, or they have a diagnosis where their prognosis is bad, and you might not be able to control that pain without medication. So when we look at side effect profiles, we look at risk versus benefit. Because now, for example, opioids will give patients sedation, constipation, some will give them nausea. But would you rather have a patient who is sleeping or a patient who is in pain? So that's usually the question I would ask myself. But ultimately, we try to keep patients on analgesics for as short a time as possible. And that's why the emphasis is on multidisciplinary team management for patients with pain, so that we can also try and minimize the analgesics where possible. And if not possible, we can use the minimum number of drugs for the pain. Instead of being on 4 analgesics, let's be at least on 1 medication.
Okay, thank you. I think we'll just take a few more because we are almost running out of our time.
Yes.
And one of the question is management of arthritis in patients over 70 who are hypertensive. Is there any that you would recommend? Yes.
The best management for arthritis is actually NSAIDs because of the mechanism of pain in arthritis. Now, a patient who is 70 with hypertension, you need at least their baseline renal function, their baseline liver function, and where possible, actually work with the orthopedic surgeon. If they're able to get a joint replacement, it would be the best instead of being on analgesics long-term because of the long-term side effects of NSAIDs.
Okay, thank you. What is nerve blocked?
What is nerve block?
Yes.
A nerve block is an anesthetic way of managing pain where the medication is used to try and block the pathway for the nerve. I think we should organize a session, Dr. Kinuthia, where the anesthetic team can take us through the kind of interventions that exist for pain, except just the medication. We can organize with one of the anesthetists to do that for us.
Okay. I think our last question will be from Dr. Anne Joroge, who is saying, great talk. Can you comment on alcoholism and chronic pain? Give your experience in practice.
Alcoholism and chronic pain. Allow me not to answer that because I'm thinking on my feet, and I'm trying to remember if I've managed an alcoholic patient with pain, and it's not coming to mind at this time. Sorry about that, Doc, but yeah, we can reserve that for another discussion.
I don't know. I think after
Yeah.
this, you have to continue answering questions. I think you can
Yes.
see you have so many pending,
Yes.
and we have actually run out of our time. I
Yeah.
was trying to be very fast so that we are able to answer as many questions, but unfortunately, you are not able to answer all of them, but I'm sure you can be able to respond. I think now we'll go to this commercial session. And for the commercial session, this is sponsored by Biopharma and is focusing on, I'm forgetting, is it pain? Yes, I'm going to invite Dr. Edgar Ombati. You have 15 minutes. And I believe you are supposed to be having something for us somewhere in between. I don't know whether that's still part of the plan. Dr. Ombati, the floor is yours now. Dr. Nafula, please continue answering the other questions if you get a chance.
Okay. Okay.
Yeah.
I'll be answering in the chat.
Yeah. Thank you. Dr. Edgar Ombati, the floor is yours. Yes.
Thank you very much, Dr. Kinuthia. So I'd like to thank Dr. Nafula for a wonderful presentation, as well as all our attendees. We're very happy to have you here today. So as Dr. Kinuthia mentioned, I'm from Biopharma, and I'd like to talk to everyone today about a fantastic product called Tamepin, which is made right here in Kenya. And we are happy to present it to our attendees today. So Tamepin is a combination product. It's made right here in Kenya, and we are presenting it as a master stroke for every pain. So you can see the ingredients. It's a combination of paracetamol, 450 milligrams, codeine phosphate, 10 milligrams, doxylamine succinate, 5 milligrams, and caffeine, 50 milligrams. So it's a right combination of ingredients, which we've listed, whereby the paracetamol is an all-rounder for every type of pain. The codeine takes care of the mild to moderate pain. As Doc mentioned, it falls under the weak opioid category. The doxylamine succinate, in this case, is used as a short-term sedative and hypnotic, and it's actually fantastic in the tension states. The caffeine in this product is beneficial, and it is a routine stimulant. So we have a right combination of power, whereby the paracetamol, we are giving the ideal dose. The codeine is in the same strength as in the syrup dose, that is in reference to the Pfizer product known for codeine. Doxylamine succinate is a light dose, and caffeine, we're presenting a sufficient dose. So Tamepin is a single combination solution for all types of headaches, including the tension headaches, which often present in the clinical setting. It is a single combination which has multiple modes of action, that is fever, analgesia, the antihistaminic effect, the hypnotic and sedative effect, as well as the anti-allergic effect. So the single combination is sufficient for all pain, as also for headache relief. Now, Tamepin also is available in the pharmacies or clinic setting as a single combination, of course, for the pain and also headache management. Tamepin is an ideal product for adults. It is a better combination than any other available in the market due to the clinically proven efficacy. Tamepin is well tolerated. It's very gentle on the stomach mucosa, and is quite with a very acceptable profile. Another thing about Tamepin is it's a proper combination with optimum strength, and it is the right solution for our patients. Tamepin is a quality product, as I had mentioned. It's manufactured right here in Kenya, so it's at a very, very good affordable price. Right now we have an offer with all the distributors. We're only doing at 9 shillings per tablet. The presentation of the pack is 20 tablets. So that's a total of 180 shillings. And that's an offer that's ongoing right now, available with all the distributors. So Pain also adds value by having multiple pain solutions in one product. Remember, we mentioned the 4 ingredients which target the pain and also address it. So Pain is the right product at the right price for the right market. That's our Pain. So as I mentioned, just remember it's made here in Kenya, and we want to buy local products. We build Kenya and we build our economy and our country. Thank you very much.
Yeah, thank you. Quite short. We seem to have a few minutes. The session is to end at 3. So Dr. Nafula, in case you'd want, you can take the opportunity to answer 1 or 2 additional questions, unless there is one specifically for Dr. Ombati. So far I've not seen anyone specifically for him. Dr. Nafula?
Yes, I'm actually trying to look at at some. I've answered some in the chat.
Yes, that's why I don't know which one
to ask. Let me just.
Yes. As Dr. Nafula is looking at the questions, I have seen a lot of questions about the slides. The slides are uploaded in the hospital website. So these ones are available in the hospital website. If you go there, you'll get all the current presentation, and also for the past symposia. Also, the recording will be available. It will again be uploaded in the hospital website. You're able to get that if you go to the website. In terms of CPDs, the CPDs are awarded, sent within 2 weeks after the session, because we have to engage someone else. When we have about 1,000 participants per session, it's difficult to send all those very fast. It takes a bit of time. As when there is a delay, let us know. If it has gone beyond 2 weeks, let us know, and we're able to sort that out. But also be understanding. If you're having webinars almost on a daily basis, then also the process of sending the CPDs can be delayed. But everyone who has attended the session will get their CPD. You can be assured of that. Dr. Nafula, have you sorted out a few questions you can address?
Okay, yeah, but I'm seeing some here that Dr. Ombati can help to answer.
No problem. You can even tell him the one you want him to take. Yes.
What is the difference between tummy pain and beta pain?
Thanks for that question. So today we are here to talk about tummy pain. Key difference I can highlight for our product is it's locally manufactured. It's a really good quality, and we believe it should take care of all types of pain, and the price also is a very good advantage, which we present to our patients as well.
So someone also wants to know the dosage of tummy pain per day in adults, and whether it can be given to a patient who is 80 years old.
Okay. So we don't recommend it to be given to children over below 12 years. So for over 12 years, you can give 1 to 2 tablets, repeated 4 hourly if necessary, but of course with a warning not to exceed 8 tablets per day.
The price, I think someone missed on the price. And then there's another question on the role of caffeine in pain in analgesics. I don't know if you're able to take those two.
Okay, yes, thank you, Doc. So about the price, that is 9 shillings per tablet at wholesale level. That's with your wholesaler. So that's, and I'd mentioned the presentation is in 20 tablets. There are 2 blisters inside of 10. So that's 180 shillings at the wholesale level. And the next question was concerning
Caffeine. Is there a role of caffeine in analgesics?
just a second. Yes, so the caffeine in this preparation works in a complementary fashion with the other products, the other ingredients. So as we target the pain.
Someone has asked that why is there a stimulant and a sedative in the combination?
I just wanted to highlight something about the caffeine that has come to mind also, that it should be fine. Just the only precaution we should approach is that it should be given with care to patients which have who present with peptic ulceration. But otherwise should be totally okay.
Dr. Ombati, there's at least one convertee. They're asking you to send them contacts for the rep. You have at least converted one person.
We are happy to have them on board, and we'd like them to get in touch with their nearest distributor, as the product is well available, not only in Nairobi, but also across the country.
Okay. I think we are coming to the close of the session. So I'll give you an opportunity to give one final comment, and then Dr. Nafula can give the final comment. Dr. Ombati?
Yes.
Make a final comment. We are coming to the end of the session.
Oh, thank you. Thank you very much, Dr. Kinuthia. Thanks. Just like to thank everyone, all the attendees for joining us today. Just a reminder about Tamepin. It's a master stroke for every pain, the combination product that's made right here in Kenya. And we're happy to present it to you guys, and we hope you can pass on its advantages to the patients, and as we walk through this journey of alleviating pain. Thank you very much.
Thank you, Dr. Ombati. And Dr. Nafula, final comment?
Yes, thank you so much for sparing your time on a busy afternoon to listen to the presentation on chronic pain. We will send out a survey. We'll work with Dr. Kinuthia to send out a survey for you to tell us the topics that you want us to cover in terms of aspects of pain management, so that I think we can improve the experience of the patients who come to us for pain interventions. Thank you.
Thank you so much. And I second what Dr. Nafula has said. Please let us know the topics you'd want covered, but we'll do send that survey so that we can organize the two additional other additional sessions. But the ones, Dr. Nafula, you mentioned with anesthesia and management for children, I think those ones are already cast in stone. We can start working on those.
Okay.
Thank you everyone who has joined. Yes. And let's see you for the next session. Thank you. Asanteni sana.